Good afternoon. This is Professor Brad Mitchell from Ivy Tech Community College. We are going to be doing the lecture over Chapter 14 from Comer, 8th edition, which is over schizophrenia. We will be discussing both the treatment, the etiology, and some of the symptoms that will add up to the diagnosis of schizophrenia, as well as some co-occurring conditions, comorbid conditions, as well as conditions that are similar to schizophrenia. If you're using Comer's 8th edition, you will have read two vignettes, one about Laura, a 40-year-old female, and the other about Richard, a 23-year-old male. After reviewing those two vignettes, you will see some of the symptoms that are very similar and some that are very different from other diagnoses that we've talked about. As we go through the lecture today, and as you've gone through your reading, you'll begin to see what some of these symptoms are and how they appear to individuals who have a diagnosis of schizophrenia, as well as what's going to add up to that diagnosis of schizophrenia. The prevalence rate of schizophrenia is much higher than what most people expect, and for others it will be a little bit lower. And so what we'll spend a lot of time on in this lecture is the process for accurately diagnosing schizophrenia, where schizophrenia comes from, looking at all the different points of view or schools of thought. We'll look at the genetic implications, whether this is a nature or nurture diagnosis. We will also look at the severity of schizophrenia. And from your reading or just from your knowledge of schizophrenia, schizophrenia is one of the more severe diagnoses that an individual can get from a psychiatric or psychological professional. Many people have gone as far as to call schizophrenia the cancer of the psychiatric world. That is actually a relatively good analysis because, like with any cancer, schizophrenia can be dormant for quite some time. It can affect the person significantly, or it can allow the person, or the person can allow themselves to cope very well throughout their entire life with the diagnosis and with the symptoms. So a good analogy, and I think it really speaks to the severity of the diagnosis itself. We'll look at the capacity of someone with schizophrenia to work and what the current and future treatments are for people with schizophrenia. According to the DSM-4, which, as we say with every lecture this semester, is somewhat of a historical document at this point as we are transitioning to DSM-5. But the DSM-4 TR criteria for schizophrenia is that you're going to have some characteristic symptoms, which means that there are some symptoms that you will see within people with schizophrenia. They may not have all of them, but they do usually share some similar pathological issues. There is a social and or occupational dysfunction. Duration must be greater than 6 months, which means that there are some differential diagnoses or some issues that can lead to a more acute psychotic disorder. But for schizophrenia to be the correct diagnosis, it has to have been present for at least 6 months. Schizoaffective and mood disorder exclusion, what that means is that if someone has schizoaffective disorder, they are not going to meet the criteria for schizophrenia. These are not diagnoses that can be comorbid with one another. Same thing with the substance abuse disorders. I think for most people it would stand to reason that if you have a psychotic disorder that is brought about by narcotic abuse, that would preclude you from a diagnosis of schizophrenia. However, there are people who will use psychiatric drugs or psychotropic drugs or illicit drugs, psychoactive drugs, that will also have schizophrenia. So simply using a substance does not preclude someone from having schizophrenia, but if we can trace the etiology back to the drug, that would not be considered schizophrenia. Same thing with general medical condition. Somebody with a brain tumor that is causing them to have visual or auditory hallucinations, we would not consider them to have schizophrenia. However, when we go over um, the medical or biological basis for schizophrenia, we're going to see that there are some significant brain issues, physiological brain issues that most people with schizophrenia have, but those would not be a general medical exclusion. Um, and there is a relationship to pervasive developmental disorders. A lot of the criteria that you're going to hear for schizophrenia sound incredibly similar to the developmental disorders that you will see in the autistic spectrum or with a person with Down syndrome. Um, these can be comorbid. You can see somebody with a developmental disability with schizophrenia. However, one normally will explain the other. When we look at the diagnostic process for schizophrenia, uh, this is much like any other diagnostic process. You're going to begin with the clinical interview. Um, but when you're looking or you're working with somebody with schizophrenia, you're going to want to look at axis 3 very, very carefully and rule out any physical or biological abnormality um, outside of the scope of schizophrenia. So a lot of people will put somebody through a CT, MRI, PET scan just to see if there's anything there. But by and large, that's really not helpful in the diagnosis of schizophrenia. It can show if there is some significant impairment, but for the most part, if somebody's to the point where they're seeking out psychiatric consult, there's usually nothing else going on with that individual that would indicate a medical issue. And therefore, the bigger things we want to look at are medical history and substance abuse in the past. Most of the time, we're gonna make the diagnosis here strictly from a mental status exam, a history, and a lot of times we're going to get that history not from the identified patient, but from somebody who is actually helping that patient get set up with psychiatric consult. What's very interesting is that a lot of times the reliability of the historical information given by somebody with schizophrenia will actually indicate issues that would lead up to a diagnosis of schizophrenia, because a lot of times with paranoid ideations or delusions of grandiosity or reference, their perception of the world will be skewed in such a way that actually having a poor historian in the client indicates that they are probably suffering from a psychotic disorder such as schizophrenia. Looking back at the history of things like phrenology, where the early psychologists or the early biopsychologists would use phrenology to rub their hands over the person's head to see if there were divots or excesses of the skull. There's really no biomarkers for the diagnosis or severity. You can't look at somebody like with Down syndrome and say, well, that person looks like they have schizophrenia, nor can we even look at the brain with the technology that's commonly used and say, wow, that's a person with schizophrenia. There's not going to be any biomarkers for the diagnosis or the severity. When we look at schizophrenia, we are looking at two marked types of symptoms. We have positive symptoms and negative symptoms. And we're not talking good and bad here. We're talking about positive and negative in the same way that we talked about it in Psych 101 with operant conditioning. In operant conditioning, when you use a reinforcer, a positive reinforcer adds something to the equation. A negative reinforcer takes something away from the equation. Both of them will increase the probability that the behavior will occur in the future. Not exactly the same with schizophrenia and with symptoms, but similar. Because what we're looking at is a positive symptom is something that is in excess of what the average or normal person, the non-psychotic person would have. So obviously hallucinations would be a positive symptom. Somebody with schizophrenia is having more hallucinations than the average or normal person. Versus the negative symptoms, those are the things that people have a poverty of. Anhedonia, which is the inability to feel any kind of pleasure, would be a negative symptom. Apraxia or positive, apraxia or alogia. Alogia is the poverty of speech. Apraxia is an affective dysregulation. These are both symptoms that are negative. Um, Restricted affect, which a lot of times is called flat affect, where people express neither pleasure nor pain, would fall along the same as alogia. Loss of volition or avolition. These are people that just become apathetic. That would be a negative symptom. And social withdrawal. A lot of times we see individuals will have social withdrawal, and it's a chicken or the egg debate of, is the schizophrenia causing them to be socially withdrawn because they have lost touch with reality, or are they losing touch with reality and that's exacerbating the schizophrenia? And we'll discuss that as we go, as we talk about schizophrenia a little bit more. Audible thoughts, those would be a positive symptom. Hallucinations, auditory hallucinations, voices arguing or commenting, thought withdrawal or insertion by outside forces, that would be a positive symptom. Thought broadcasting, this is a hallucination, a hallucination and a delusion, in which a person may even see their thoughts leaving their head, but the delusional thought is that other people are able to receive their thoughts because they're being broadcast right out of their brain. And then delusional perceptions, those are just the way that the person interprets things. Slightly different from a hallucination, and we'll get into that here in just a second. So the symptoms, when we look at this dimensionally, when we look at this as a list, the psychotic symptoms, the two major psychotic symptoms in schizophrenia are hallucinations and delusions. And the best way to differentiate the two is to just remember that a delusion is an irrational thought, while a hallucination is a perception that is either incorrect or is not in line with the actual sensation that is coming in. So there may be the lack of a sensation, or the sensation may be coming in and being interpreted incorrectly. So with a visual hallucination, the person may see something that there is no sensation of. So if I am sitting here and I see 4 or 5 people standing in front of me, but there are no people there, that means that the light waves that should be bouncing off their body, coming back in through my eyes, going to my occipital lobe, they don't exist. So my hallucination is completely fabricated of my mind. And so when we think about a hallucination, we have to remember that we're talking about something that can be one of two things. It can be something that is completely made up of the mind, or it can be something that is a misinterpretation of sensations that are actually out there, and the person is just misinterpreting or taking the information in incorrectly. One of the more interesting side notes that Comer's textbook talks about is research that's done on what's called the Broca's area. The Broca's area is a part of the brain that actually helps us interpret speech, vocabulary, syntax. Broca's area is activated if we hook somebody to an fMRI or a CAT scan or a CT, where we're actually able to see the activity of the brain. When somebody is fabricating a sentence and they are making up words and sentences, the Broca's area lights up with activity. And we look at people with schizophrenia who are actively engaged in an auditory hallucination. They are hearing something that is not really there. And when they report that those auditory hallucinations are words, are sentences, we can actually see the Broca's area light up the same way as if they were talking. So what this means, or what we believe this to mean, is that the Broca's area is actually activating and making up these words or this syntax or these sentences, and the mind is not able, the brain or the mind is not able to differentiate whether the Broca's area is creating these words or if some outside force is creating these words. And this is the major difference between somebody with schizophrenia and somebody who's not when it comes to auditory hallucinations. For the most part, a a non-schizophrenic individual, which we'll loosely call a normal person, knows when they're talking to themselves. They know when they're making up a thought. They know when they're making up sentences. But because there's some disconnect, there's some neurological uh, implications within the brain, the Broca's area is actually making up, or there's at least activity going on in the Broca's area, which would indicate that just as if it's activated in speech production, it's also activated in auditory hallucinations. So there seems to be somewhat of a disconnect there. Again, looking at the negative symptoms: impoverished speech, lack of motivation, asociality, decreased affect, or flat affect. And then the neurocognitive impairments: memory, attention, social cognition, disorganized speech. These are all, they could be categorized as psychotic, but they are neurocognitive impairments. Let's look at the actual prevalence, the epidemiology of schizophrenia and the prevalence within society. The lifetime prevalence is about 1%, and usually, again, we're looking at the United States here. There is no epidemiological difference between different races or different cultures, so we're looking at 1% across the board. And this is one of those diagnoses that we're actually at a 1-to-1 ratio, or possibly even higher in males than females. Usually we see the anxiety disorders or the mood disorders, we see a lot of 2-to-1 ratio, female being the 2 with male being the 1. Here we're seeing at least a 1-to-1 ratio, and sometimes we look at numbers that are even closer to 2-to-1 male to female. The onset in men is usually about the time a man is fully in adolescence. It's not usually the beginning of puberty, but adolescence has set in and they're starting to mature. Historically, we would say this is the cusp of young adulthood, whereas for females, it's more in middle to later young adulthood, 25 to 34, and there's not a lot of research to show why this occurs. A lot of implications with the dopamine theory of schizophrenia is that overproduction is happening in males at a younger age versus females at an older age, which kind of goes in hand in hand with sexual maturation and the sexual peak ages for individuals. Usually men hit their sexual peak at a little bit younger age, and that's when they're getting a lot of dopamine production, whereas females tend to hit their sexual peak at a little bit older age. That is purely conjecture. That is purely looking at the dopamine theory, nothing that has been empirically proven. The kind of the course of schizophrenia, looking at this from a male perspective because of the way that the dates are, the individual a lot of the times will, in the pre-morbid phase of schizophrenia, this is where they have the vulnerability to schizophrenia, but they're not actively engaging. And what you're seeing here is a person who probably isn't getting a lot of treatment, or if they are, they're relapsing from it. And you're seeing that the functionality is fluctuating between a functional individual and somebody who's below optimal functioning level. So what you're normally seeing here is that people do not, under normal circumstances, just kind of stay at a static schizophrenic baseline. That they have good times, they have bad times, they actually have good years and bad years. While this doesn't indicate what kind of treatment is occurring, the title of this article, that it's the pathophysiology of a treatment-resistant schizophrenic, indicates that this person is treatment resistive. Unfortunately, the title doesn't tell us whether the person is resisting treatment or if the treatment that is being given, normally a antipsychotic medication, is actually not working for that individual. Schizophrenia is, again, considered to be one of the more severe psychiatric disorders that we have. People with schizophrenia have differing levels of symptoms and and how they function with that. Uh, some people will be able to function very well within society. Um, I think my favorite example of that would be Dr. John Nash, who the movie A Beautiful Mind is based off of. He had decades of lucidity, and he's had decades of pathological symptomatic times where his schizophrenia was debilitating, and he needed to be hospitalized or institutionalized. And even today, he is still symptomatic, but he is able to control it. Very similar to somebody with ADHD who, and I'm not comparing schizophrenia and ADHD in severity, but a lot of times after years and years of having ADHD, uh, as people get older, they learn how to deal with it on their own, be it by diet, be it by how they function in their job and in their life, and at an earlier age they just can't cope with it as well as they can as when they're older. Schizophrenia is kind of similar in the fact that a lot of times people will be able to deal with it a little bit better as they grow. Um, the level of care is going to be related to the symptoms, and the amount of treatment that an individual gets is not, there's no set amount. It's dependent on what that individual is experiencing. The severity of the psychotic symptoms are related to a lot of different factors. Remember, psychotic being hallucinations and delusions. What we look at here is how distracting are the symptoms. Are these auditory hallucinations just something that is underneath the surface? Um, or is it debilitating? Is it voices that you can't get rid of? Um, Going again back to Psych 101, we have the idea of habituation. Habituation is when you hear a stimulus or you hear a sound or you're sensing something that is constantly there, like the air conditioning unit in your car. If you have, or even your engine of your car, as you're driving, when you first turn on the air conditioning, the blowing sound is very loud. But as you drive for a while, you phase it out. It becomes part of the background until it's brought into your consciousness again. A lot of times for people with psychosis, these auditory hallucinations will be habituated, whereas it's part of the background, it's part of the noise, it's part of their milieu, and so it may not be as distracting. And again, this speaks to the concept of as people get used to the diagnosis and get used to the disorder, it's how well they function with it. Do they influence behavior? Do the hallucinations make commands? Do they make them engage in things? Do they cause suffering? And do they cause social impairment? One of the biggest ones are paranoia and suspiciousness. That's going to impact and increase the severity of schizophrenia. The severity of the negative symptoms are usually related to social isolation, a little bit of apathy, not really caring about what's going on in other people or even within themselves, and lack of expressiveness. That blunted and flat affect will oftentimes have social implications in individuals. The severity of the cognitive impairments are related to basically just the fact that they have them, the issues with concentration and memory, the inability to interpret social signals, or the misinterpretation of social signals. Somebody asking a question about how you're doing today. If you have, those ideas or those delusions that are paranoid in nature, a social signal of just, hey, how are you doing today, may be interpreted as a very suspicious question or a too personal a question, or going down the slippery slope. If somebody is thinking that they're broadcasting their thoughts, they may say something out loud but think something else, trying to test whether or not this person can read their thoughts or read their mind. Pharmacological treatment of acute, meaning schizophrenia that is not symptomatic all the time. Antipsychotic medications will oftentimes decrease the severity of psychiatric or psychotic symptoms. Usually will not do away with them completely, but they're going to decrease the severity. There are some side effects that people tend not to like. Most of these involve things that don't have anything to do with the actual symptoms that are being treated. There's a lot of sexual side effects. There's a lot of affective side effects. There's a lot of behavioral side effects that people don't tend to like. And antipsychotics are relatively ineffective for the negative and cognitive impairment. So they're really good at getting rid of psychotic positive symptoms, such as hallucinations and delusions, but the other ones are much more treatment resistant. Um, the antipsychotic medications are really effective at preventing relapse in stabilized patients. However, once the effectiveness or the efficacy of the drug wears off, most patients will stop taking the medications because they feel like they're not working. This is exacerbated by the fact that sometimes their symptoms will come back and the paranoid ideations will come back, causing them to even further decrease their medication compliance. And so they'll become very suspicious of anybody trying to get them to take their medications once the effectiveness starts to wear off, and it becomes a very slippery slope. The clinical challenge is that a lot of people with schizophrenia either have had substance abuse issues in the past, or will try to treat their schizophrenia with a substance before seeking out psychiatric help. And so a lot of times it will be difficult if somebody says, yes, I have a history of chronic LSD usage or heroin usage. A lot of times the diagnosis of schizophrenia will be pushed aside, um, hoping that possibly, if we stop using the LSD, we stop using the heroin, we stop using the illicit drug, the psychotic symptoms will go away. Unfortunately, a lot of times people are trying to manage their own psychosis with a hallucinogenic drug or a psychoactive drug, and failing to treat them because of this is actually just going to make it worse. This concludes the lecture for schizophrenia. Specific information that you may have questions about, we can address via email at bmitchell@ivtech.edu or in class. A few notes at the end of this. There are other psychotic disorders that we did not address in this lecture, such as brief psychotic disorder, schizophreniform, schizoaffective disorder, delusional disorder, and substance-induced psychotic disorder. I do want to talk about a couple of those very quickly. Schizophreniform is essentially a differential or rule-out based diagnosis for schizophrenia. Schizophreniform is, if you remember that schizophrenia needs to be present for at least 6 months before the diagnosis to be valid. If somebody were to come in and say, I've been having these delusions, I've been having these hallucinations for the last 3 months, schizophreniform would be the correct diagnosis to give that person. It's a transitive diagnosis, meaning that eventually it's going to turn into something else. Schizophreniform is not something you will have for your entire life. If after 6 months or after 3 months the symptoms persist, schizophreniform naturally rolls into schizophrenia. If they go away, sometimes people will just let it go and say that it was an acute schizophreniform issue. Other times it'll beg the question of, well, why did that happen and what do we need to be looking for in the future? So just remember, schizophreniform is a transitive psychotic disorder. It is acute in nature because if it's chronic, it will lead to schizophrenia. And then schizoaffective disorder, we already discussed just briefly. Schizoaffective disorder is the marked symptoms of both schizophrenia and a major depressive episode or a manic episode. So the way that I like to describe this very simply is you take schizophrenia and you take one of the bipolar disorders and you slap those two things together and you have schizoaffective disorder. As you can see, this is one of the most severe disorders you can have, because not only are you having the psychotic issues of schizophrenia, but you're having the mood dysregulation of a bipolar or a depressive disorder. Can be incredibly difficult to work with. However, the interesting thing is there is a newer drug on the market called Invega that was designed for schizoaffective disorder, and it has been very successful in individuals with schizoaffective disorder, and it's also been used pretty prominently with people with developmental disabilities, people who have affective or mood dysregulation, a lot of times even aggressive tendencies. The schizoaffective drug Invega has been successful for those individuals in decreasing those violent behaviors or those aggressive type of behaviors. one passing or one final note about the treatment for schizophrenia. There are the psychoactive drugs or the psychiatric drugs have kind of taken over the treatment of schizophrenia. However, institutions can set up atmospheres that are more conducive for treatment. The one thing that has really taken hold, and it's not really anything that's going to cure schizophrenia, but something called milieu therapy. And milieu therapy is basically just setting up an environment that is comfortable for individuals with schizophrenia and not so clinical and not so jarring to them when they come in. And this is, it's effective for most psychiatric disorders, but it's something that is very effective for people with schizophrenia. Looking at the antipsychotic medications, they can be incredibly harsh. There are side effects that are somewhat debilitating, things such as Parkinsonian symptoms, because of the dopamine theory of schizophrenia, that too much dopamine leads to schizophrenia. We know in Parkinson's there's a deficiency of dopamine, so people who take too much antipsychotic medications oftentimes will get Parkinson's syndrome. Tardive dyskinesia, this is essentially tremoring or again, Parkinson's-like syndrome, specifically from taking specific antipsychotic drugs, and also very prominent out of the drug lithium. That is a very common result of taking lithium as tardive dyskinesia. Psychotherapy is not considered to be an incredibly effective modality by itself. Psychotherapy, including family therapy and cognitive behavioral therapy, can be seen as effective when you take it, when you combine it with antipsychotic medications. But even going back to the 1940s, it was well known that Freudian psychoanalysis wasn't going to be effective for somebody with a psychotic disorder. And this is actually a statement made by the famed lobotomist Walter Freeman, who was known in the United States as the predominant lobotomist through the 1940s and 50s. He would speak to psychoanalysts very frequently and really, just talk about the effect of his lobotomies and how it would oftentimes diminish psychotic symptoms, and would ask them, what does your psychotherapy or your talk therapy do? It really can't do anything to the psychotic patient. It can't really get through to them, without some other modality starting it. At that time, it was lobotomy. Today, we're not prescribing lobotomies for people with schizophrenia, but psychotropic medications really do start the process. But it's important that psychotherapy be a part of that treatment as a whole. So if you have any questions, please feel free to email me, bmitchell@ivytech.edu, or see me in class. Thank you for your time, and I will see you in class.
It's perhaps the most stigmatized and misunderstood psychological disorder of them all, even among psychologists. Maybe because it's pretty rare, affecting about 1% of the population, schizophrenia causes more anxiety in the media, in the public, and even in doctors' offices than any other mental illness. As a result, its sufferers have often been shunned, abused, or locked up. And among the many fallacies that surround the disorder is simply what it means. The word schizophrenia literally means split mind, but contrary to popular belief, the condition has nothing to do with a split in personality or multiple personalities. The term refers instead to what's sometimes called a split from reality. Multiple personality disorder, now known as dissociative identity disorder, is a totally different type of condition, a kind of dissociative disorder. And these two are shrouded in misconceptions, partly because they were the subject of probably the greatest psychological hoax of all time. While many of us can relate on some level to the emotional swings, nervousness, and compulsions that come with mood and anxiety disorders, it can be a lot harder for those without direct experience to relate to the symptoms of schizophrenia and dissociation. Unfortunately, we tend to fear and avoid what we don't understand in each other, whether it's a friend or family member or just some stranger on the bus. But thankfully, part of the psychologist's job is to demystify the things that can happen in our heads, and as is often the case, understanding may be the key to compassion. Schizophrenia is a chronic condition that usually surfaces for men in their early to mid-20s and for women in their late 20s. For some, the disorder comes on gradually, but for others it can arise more suddenly, perhaps triggered by stress or trauma, although no event can actually cause the disorder. Once thought of as a single discrete condition, schizophrenia is now included in the DSM-5 as a point on a spectrum of disorders that vary in how they're expressed and how long they last, but they share similar symptoms. Schizophrenia spectrum disorders are currently thought of as characterized by disorganized thinking, emotions, and behaviors that are often incongruent with their situations, and disturbed perceptions, including delusions and hallucinations. They all involve a kind of loss of contact with reality on some level. The resulting behaviors and mental states associated with this break from reality are generally called psychotic symptoms, and they usually impair the ability to function. When someone's experiencing psychotic symptoms, their thinking and speech can become disorganized, rambling, and fragmented. This tendency to pick up one train of thought and suddenly switch to another and then another can make communication painfully difficult. People exhibiting these symptoms can also suffer a breakdown in selective attention, losing the ability to focus on one thing while filtering others out. In extreme cases, speech may become so fragmented it becomes little more than a string of meaningless words, a condition given a name that sounds like its own kind of non sequitur, word salad. Classic schizophrenia is also often marked by delusions or false beliefs not based in reality. These delusions can be rooted in ideas of grandeur, like I'm the Queen of England, or I won an Olympic gold medal for the luge. Or they can become narratives of persecution and paranoia, believing your thoughts and actions are being controlled by an outside force, or that you're being spied on or followed, or that you're on the verge of a major catastrophe. And there are some complicated variations on these delusions, like feeling that you've died or don't exist anymore, or that someone is madly in love with you, or that you're infested with parasites. Delusions of one kind or another strike as many as 4 out of 5 people with schizophrenia. While some delusions can seem fairly logical, they can also be severe and bizarre and frightening. Unfortunately, many of the most memorable examples of people suffering from severe delusions come from serial killers, and yeah, while Son of Sam did claim that he was taking orders from his neighbor's dog, that kind of stuff is in the tiny minority. Brian Wilson of the Beach Boys and Syd Barrett of Pink Floyd have both suffered psychotic symptoms. And then, of course, there's John Nash, the Nobel Prize-winning American mathematician and subject of the movie A Beautiful Mind. Through proper treatment, some people with schizophrenia have not only learned to live with their illness, but also made fantastic creative contributions to the world. Many people with schizophrenia also suffer from perceptual disturbances or sensory experiences that come without any apparent sensory stimulation, like hallucinations. This is when a person sees or hears something that isn't there, often lacking the ability to understand what is real and what isn't. Auditory hallucinations or hearing voices are the most common form, and these voices are often abusive. It's as if your inner monologue, that little conversation that you have with yourself, or the random things that float through your head, were somehow coming from outside of you. It's as if you couldn't sort out whether the voices in your mind were internal and self-generated or external and other-generated. To me, it sounds terrifying. Other common symptoms include disorganized, abnormal, or incongruent behavior and emotions. This could mean laughing when recalling a loved one's death, or crying while others are laughing, acting like a goofy child one minute, then becoming unpredictably angry or agitated the next. Movements may become inappropriate and compulsive, like continually rocking back and forth or remaining motionless for hours. Broadly, most psychotic symptoms fall into 3 general categories traditionally used by psychologists: positive, negative, and disorganized symptoms. Positive symptoms are not what they sound like. They're the type that add something to the experience of the patient, like, for example, hallucinations, or inappropriate laughter, or tears, or delusional thoughts. Negative symptoms refer to those that subtract from normal behavior, like a reduced ability to function, neglect of personal hygiene, lack of emotion, toneless voice, expressionless face, or withdrawal from family and friends. Finally, disorganized symptoms are those jumbles of thought or speech that could include word salad and other problems with attention and organization. Symptoms like these are useful in diagnosing a disorder on the schizophrenia spectrum, but there's a physiological component too. Like many of the disorders we've talked about, schizophrenia has been associated with a number of brain abnormalities. Postmortem research on schizophrenia patients has found that many have extra receptors for dopamine, a neurotransmitter involved in emotion regulation and the brain's pleasure and reward centers. Some researchers think that overly responsive dopamine systems might magnify brain activity in some way, perhaps creating hallucinations and other so-called positive symptoms as the brain loses its capacity to tell the difference between internal and external stimuli. For this reason, dopamine-blocking drugs are often used as antipsychotic medications in treatment. Modern neuroimaging studies also show that some people with schizophrenia have abnormal brain activity in several different parts of the brain. One study noted that when patients were hallucinating, for example, there was unusually high activity in the thalamus, which is involved in filtering incoming sensory signals. Another study noted that patients with paranoid symptoms showed overactivity in the fear-processing amygdala. So schizophrenia seems to involve not just problems with one part of the brain, but abnormalities in several areas and their interconnections. But what might be causing these abnormalities? Earlier I mentioned how a stressful event might trigger psychotic symptoms for the first time, even though it can't actually create the disorder. Psychologists call this the diathesis stress model. This way of thinking involves a combination of biological and genetic vulnerabilities, diathesis, and environmental stressors, stress, that both contribute to the onset of schizophrenia. This model helps explain why some people with genetic vulnerability might not always develop schizophrenia, and why the rates of schizophrenia tend to be higher with some degree of poverty or socioeconomic stress. And it seems clear that there is some kind of genetic predisposition for the disorder. The 1 in 100 odds of developing schizophrenia jump to nearly 1 in 10 if you have a parent or sibling with the disorder, with about 50-50 odds if that sibling is an identical twin, even if those twins were raised apart. One recent landmark 7-year study looked at genetic samples across 35 countries, examining more than 35,000 people with schizophrenia and another 110,000 people without the disorder. The study identified more than 100 genes that may increase the risk of schizophrenia. As expected, some of these genes involve dopamine regulation, but others are related to immune system functioning. Researchers continue to tease out what is exactly going on here, but many are hopeful that these new findings will lead to better treatment. Clearly, schizophrenia is a challenging disorder to live with and one that's hard for outsiders to understand, but maybe even more rare and more elusive are the dissociative disorders. These are disorders of consciousness, called dissociative because they're marked by an interruption in conscious awareness. Patients can become separated from the thoughts or feelings that they used to have, which can result in a sudden loss of memory or even change in identity. Now, we might all experience minor dissociation at times, like maybe the sense that you're watching yourself from above, as in a movie, or like you're driving home and get so zoned out that suddenly you find yourself in front of Taco Bell thinking, like, how did I get here? Those things would generally fall into the normal range of dissociation, but most of us don't develop different personalities. Dissociative disorders come in several different forms, but the most infamous of the bunch is probably dissociative identity disorder. This has long been known as multiple personality disorder, and yes, it is a thing. It's a rare and flashy disorder in which a person exhibits 2 or more distinct and alternating identities, and the best known case was that of Shirley Mason, whose story was famously rendered in the 1973 bestseller Sybil, and later in a popular miniseries. The book was marketed as the true story of a woman who suffered great childhood trauma and ended up with 16 different personalities, ranging from Vicky, a self-assured French woman, to handyman Sid, to the religious and critical Clara. The book became a craze, and within a few years, reported cases of multiple personality skyrocketed from scarcely 100 to nearly 40,000. Many believe the book was essentially responsible for creating a new psychiatric diagnosis. It turns out, though, Sybil's story was a big fat lie. Yes, Shirley Mason was a real person, and one with a troubled, traumatic past and a number of psychological issues. As a student in New York in the 1950s, she started seeing a therapist named Connie Wilbur and taking some heavy medications. And somewhere in there, maybe because she was coaxed, or maybe because she wanted more attention, Shirley started expressing different personalities. Dr. Wilbur built a career and a book deal out of her star patient, even after Shirley confessed that her split personality was a ruse. The Sybil case is a powerful reminder that we we really don't understand dissociative disorders very well, or even know if they're always real. Indeed, some people question if dissociative identity disorder is an actual disorder at all. But some studies have shown distinct body and brain states that seem to appear in different identities, things like one personality being right-handed while the other is left-handed, or different personalities having variations in their eyesight that ophthalmologists could actually detect. In these cases, dissociations of identity may be in response to stress or anxiety, a sort of extreme coping mechanism. Either way, the debate and the research continue. Today, we talked about the major symptoms associated with schizophrenia spectrum disorders, including disorganized thinking, inappropriate emotions and behaviors, and disturbed perceptions. We also discussed brain activity associated with these disorders and talked about their possible origins, including the diathesis stress model. You also learned about dissociative disorders and dissociative identity disorder in particular, and the scandal that was the Sybil case. Thanks for watching, especially to all of our Subbable subscribers who make Crash Course possible. To find out how you can become a supporter, just go to Subbable.com. This episode was written by Kathleen Yale, edited by Blake DiPestino, and our consultant is Dr. Ranjit Bhagwat. Our director and editor is Nicholas Jenkins. The script supervisor is Michael Aranda. He is also our sound designer, and the graphics team is Thought Cafe.